Hi. So today our topic is going to be regarding passive versus active immunity. So first of all, passive immunity is when your body is introduced to pre-formed antibodies. So basically, you don't make those antibodies yourself. You are literally injected with those antibodies. While in active immunity, your immune system is exposed to an antigen, right? And it produces its own antibodies and memory cells. Now, passive immunity is quick with onset because the antibodies are literally introduced into your body and they immediately start performing their functions. But in active immunity, the onset is slow because your body has to create those antibodies first. Next, passive immunity is short lived because the transferred antibodies are gradually broken down by the body, and since no memory cells are formed, they cannot be replaced. In active immunity, the antibodies produced are long lasting, and memory cells are also formed to replace them. In passive immunity, no memory cells are formed, while in active immunity, memory cells are formed. That means when you are infected the second time, you will have a stronger and a quicker immune response. Now, some examples of passive immunity are going to be IVIG, which is literally IV immunoglobulins. And these are given in different conditions. And one such condition is an Rh negative mother pregnant with an Rh positive baby. Okay, so this is what goes on. Let's say this is the mother, right? And this is the baby. And this barrier in between them is the placenta. Now, the mother is Rh negative, right? And the baby is Rh positive. Now, what happens is that since the mother is Rh negative, that means she will have antibodies against Rh antigen, which the baby has. Now, the placenta, as long as it is present and and there is no mixing of blood between the mother and the baby, so there is no issue. But let's say the baby is delivered. Now what happens is obviously the placenta is removed and some of the baby's blood can enter the mother's blood. Now, since the baby's RBCs contain the Rh antigen, right? So let's say this is an RBC and this is the Rh antigen on top of it. The mother can be sensitized, right? And this is important in high yield. The mother can be sensitized and she starts forming antibodies against the Rh antigen. Now, this is not a problem until she is pregnant with another Rh positive baby the next time. Now, the reason why it is dangerous because now the IgG antibodies that were formed from the previous exposure to the antigen can now cross the placenta and they can attack the RBCs of the baby. And this is a very high yield concept. I will be talking about this disease later on, but this is important. So when the IgG antibodies cross, they start attacking the RBCs of the baby, and that can lead to hydrops fetalis. And that's a very major complication. So how do we prevent this condition from happening? What happens is that in the first pregnancy, when the mother is Rh negative and the baby is Rh positive, the mother is given what is known as RhoGAM. RhoGAM is basically anti-Rh antibodies. So these are antibodies that are directed against Rh antigen. Now you must be thinking, wait, this is weird because we just discussed that the mother will be forming antibodies against the Rh antigen. So you might be wondering, how is that? How is this going to be the prevention? Well, these antibodies, right, these Rh antigen antibodies, they will destroy any fetal Rh positive RBCs that enter the maternal circulation. And that is important because we want to destroy those RBCs before the mother's immune system can recognize them and make its own antibodies, because then she will be sensitized. So the main goal is to prevent the maternal sensitization, and that's why we give RhoGAM, which are basically anti-D or anti-Rh antigen antibodies. All right. So if these are the fetal RBCs that are traveling in the maternal circulation, these antibodies will quickly attack them and finish them off before the mother's immune system becomes sensitized to them and it starts forming its own antibodies. So that's one reason why we give IVIG to these mothers, right? And this is a high yield condition. Another such condition is known as ITP. ITP is immune thrombocytopenic purpura. And this is an autoimmune disorder where basically antibodies are formed against your own platelets. I will talk about this disease in specific later on, but all you have to know is that your body forms antibodies against your own platelets. Now, that leads to increased peripheral destruction of platelets. Okay, so obviously, if this is your platelets and you have antibodies that are sticking it, right? Antibodies are coating the platelets, and when the platelets enter the spleen, right? So let's say this is your spleen. So what happens is, since it is coated with antibodies, the macrophages inside the spleen will start phagocytosing them, and that leads to increased platelet destruction. And because of this, when you do the labs, you will see that this patient has decreased platelet counts, right? It is because of this peripheral destruction. Now, why do we give IVIG in these patients? The reason we give them is because we want to reduce the platelet destruction. So when we give them these antibodies, right? So let's say these are your IVIGs. So these travel into the spleen, and then the macrophage can be focused on this IVIG, right? So it's kind of like a distraction, so that they don't destroy those platelets, but they rather destroy these immunoglobulins. Now, this is one of the reasons why we why we give IVIG to these patients, so that we can buy some time. And the permanent treatment for this for this disease is basically splenectomy. You remove the spleen itself, right? So that's one of the reasons why we give these patients IVIG. It's basically to distract the macrophages, to interfere with macrophages mediated clearance, right? And to buy some time so that we can do a splenectomy for these patients. And next, we have antitoxins. So antitoxins are antibodies. These are preformed antibodies that are directed against bacterial toxins. And they provide immediate protection by neutralizing these toxins already present in the body. Some very important examples are like tetanus IG, right? Rabies IG. So tetanus and rabies, and also botulism. So let's say that you have some kind of accident on the road, right? And now you have a very increased risk of being infected with tetanus. So you go to the hospital and they start injecting you with the antitoxins, and those antitoxins are basically your tetanus immunoglobulins. Next, you have maternal IgG and IgA. So you know that maternal immunoglobulins, especially IgG, can cross the placenta and it can provide immune protection to the baby up until 6 months. And also the breast milk secretions, they contain IgA, so that can also provide some protection to the baby until they start developing their own antibodies. Now, examples of active immunity, they are obviously vaccines, right? So whenever we give a vaccine, it's basically exposing the patient's immune system to the to antigens, and that can lead to development of memory cells and immune response and antibodies, right? And the other way is literally natural infection.